Everyone, my name is Maya Luria with TMC for Seniors, and it is the beginning of Heart Month. So I'm so excited. We've got Dr. Greg Koshkarian here with us today. He is a cardiologist with Pima Heart and Vascular. Greg has done some great talks for us already, and I'm happy that he's here because he always gives us incredible information about what we need to know to keep ourselves heart healthy. And so welcome, Greg.
Thanks very much, Maya. I hope I can live up to that introduction.
So you may be watching us today on either our YouTube channel or our Facebook page. If you have any questions, please feel free to leave them in the comments. And afterwards, we'll have some times where I'll be able to ask any questions that come up. So I'll go ahead and let you get started.
All right, thanks again. So I was asked to give this talk on heart disease, and you can see the title there, how it starts, how it progresses, what you can do. Next slide. And I broke this talk up into several parts. And I want to actually start by defining what exactly is heart disease that's in the title. How does atherosclerosis develop? What are the symptoms of ischemia? And we'll define what atherosclerosis and ischemia are. And once we've established that, what causes it? How do we detect it? And what do we do about it when we find it? Next slide. So what is heart disease? Patients often ask me, do I have heart disease? And most of the time the answer is yes, because if they're seeing me, they probably have heart disease. But heart disease is a very broad category, and this lecture isn't going to be talking about all heart disease, but I just wanted to show this slide to give a little overview of what the different types of heart disease are. So there's mechanical types of heart disease, where, say, the heart muscle isn't functioning well, or the heart valves are not functioning well. There is electrical disease. People can have too many extra beats. It's normal to have extra beats here and there, but some people have thousands a day, and that's also a type of disease. People can have slow heart rhythms where their electrical impulses do not generate as frequently as they should, or they generate appropriately, but when they're traveling down to the pumping chambers, they get blocked somewhere, and we call that heart block. Those are slow heart rhythms. And then there's fast heart rhythms, things like ventricular tachycardia or supraventricular tachycardia. Atrial fibrillation is a very common electrical problem, more common as we get older. So these are the electrical problems of the heart. But what this talk is going to focus on is the heart disease that we often call plumbing issues with blood flow to the heart due to blockage of the coronary arteries, so-called coronary heart disease or coronary artery disease. Next slide, please. All right, the pathophysiology of coronary artery disease. So what is pathophysiology? It really means, what is the process of the illness? How does it develop, and what does it mean? Next slide. So I'm going to do a little biology here. Don't get too intimidated. This whole talk won't focus so much on images of arteries like this, but I do want to try to get across that heart disease that we're talking about, coronary heart disease, is a disease of the blood vessel. In fact, it's specifically a disease of the inner lining of the blood vessel. So atherosclerosis, which is in a sense Greek for hardening of the arteries, and by the way, that refers to what people discovered when people died of heart disease, is that their arteries were very stiff and hard, and that's because calcium built up in the arteries. And we'll talk later about the fact that that isn't the main cause of atherosclerosis, but it is something that develops along with it. So atherosclerosis develops because the endothelium, which is the inner layer of the vessel there, doesn't work the way it should. So a normal endothelium wants the blood to flow nice and smoothly. It keeps blood cells like platelets and white blood cells from adhering to it. It prevents cholesterol from attaching, and it prevents all of these things from migrating through the endothelial spaces into the subendothelial layer. So in this image, that inner layer is the endothelium. The intima is that, along with that yellow part that we call the internal elastic lamina, and then this middle area is the muscle cells of the of the artery. That's where arteries develop their vascular tone. The arteries can relax. If they want more blood flow, they can constrict if they need less blood flow. And then the outer layer is the adventitia, and that's kind of a connective tissue that is supportive for the artery. It helps it attach to other structures. It also has its own blood vessels that can run in it that supply a large artery with blood, because some arteries are big enough that the diffusion of sugar and oxygen and other things is too far away from the outer layers, and so the blood vessels themselves have a little blood supply. There's also neurons, a neurologic input. So arteries are complicated organs, and as I said, atherosclerosis is a disease of the endothelium of the artery. Next slide, please. So as the artery becomes more diseased, these inflammatory cells like T cells and macrophages, they start to migrate inside the vessel, the subendothelium as we call it, and cholesterol builds up there. The cholesterol is engulfed by cells called macrophages, and they become termed foam cells, and they're called foam cells because fat molecules are kind of foamy looking. So these cells that engulf the fat become foamy in appearance, and you've got other things in there. There's platelets that are adhering, smooth muscle cells that migrate in there. Next slide. And in the further development of plaque, these foam cells actually break open so that you've now got this acellular debris of a mixture of dead cell membranes and substances, cholesterol, molecules like tissue factor. These are all things that will figure in greatly when we talk about how a heart attack occurs. But in this setting right now, you have what's called an atherosclerotic plaque. It's inflammatory. It's almost like a little abscess, and the artery tries to protect the bloodstream from this plaque by building a wall around it, and we call that the fibrous cap. And that's a collection of smooth muscle cells and fibrous tissue that walls off this growing plaque from the bloodstream. Next slide. So to take a little digression, I want to explain that in the slides you saw, what we demonstrated was the plaque that's kind of growing, and it looks like it kind of grows gradually and it grows inward. And that was the idea for decades, that heart disease occurred gradually, that eventually the artery occluded because so much plaque had built up. But there was something the matter with that model, because what we discovered was that when we started doing angiograms in the 1980s and 1990s, we saw that people who'd had an angiogram a few months before a heart attack, that vessel that caused the heart attack often wasn't the most narrowed vessel. In fact, it often didn't have more than a 50% blockage in it. And so that made people kind of wonder, maybe things aren't progressing quite the way we thought. And around that time, there was a pathologist by the name of Glakoff that did some autopsy studies and discovered that people's arteries accommodate the plaque as it's growing. So you see the normal vessel on the left there with a nice big lumen, and then you see plaque developing in the middle and in the next section, but the lumen looks exactly the same because the artery is actually growing to accommodate this enlarging plaque. We call this positive remodeling. Next slide. And this occurs until about 40% of the cross-sectional area of the artery is occupied by plaque. And in this schematic, you see kind of a version of what you saw on the previous slide, but in the fourth image, you now see that the lumen is starting to get encroached upon. And if you measured how narrow that artery is compared to the ones to the left, we would say it's about maybe 50% narrowed relative to the opening of the one to its left. But you can see that there's a huge amount of plaque there. If you could measure the cross-sectional area, probably about 70 or 80% of the area of that artery is now occupied by plaque. So when an artery starts to first become narrowed and has maybe a mild or maybe moderate narrowing, it already has a lot of plaque there. Next slide, please. So this gets to what happens when we have what's called an acute coronary syndrome. Acute coronary syndromes are unstable syndromes. People have unstable angina or heart attacks. And what usually precipitates this is something called plaque rupture. So you remember that this plaque is growing. It's got all sorts of substances inside the plaque, and that fibrous core can sometimes become, the fibrous cap can sometimes become thin. It's thinned sometimes due to molecules that are secreted by the inflammatory cells in the plaque that actually degrade that cap and make it thinner and more susceptible to breaking open. And something that might trigger it to break open would be stress that caused the blood flow to be more quick and cause more shear stress on it. Sometimes the plaque can rupture from within due to bleeding from within the plaque. So this plaque is so big that it develops its own little blood supply. And these little fragile vessels can break, they can bleed, and the pressure from the blood inside the plaque can push the plaque outward and break through that cap. Next slide. So when a plaque ruptures, as you see in the schematic there, in the third one down and blown up to the right there, the plaque starts to extrude into the bloodstream. Now that by itself isn't what causes the heart attack, because the plaque doesn't suddenly get massive in size, and if it was only 50 or 60% occluding the vessel before, it's not going to occlude it much more when it breaks open. But what happens is the things inside the plaque activate the clotting cascade, the bloodstream. I told you that inside this plaque are inflammatory cells, cellular debris, cholesterol, tissue factor. These are all things that activate the clotting system. And the reason that the clotting system gets activated is that evolutionarily, our clotting system is programmed to be activated when it senses injury to the vessel. Evolutionarily, the main risks and the main things that happened to blood vessels was they got torn when cave people were attacked by saber-toothed tigers, or people got stabbed by a spear, or they fell from a tree, something like that. And so the body's mechanism for preventing hemorrhage was to create a system where the bloodstream could sense an injury to the vessel, activate the clotting system, and wall off that area of injury. So you might lose the blood flow to that particular area, but you would save the body's life by not allowing hemorrhage to occur. So what we know is that this clotting event occurs due to plaque rupture, due to activation of the clotting system. It's not that clots are floating around in the bloodstream and lodge by chance into the artery. It's that the blood is fine until it comes into contact with this abnormal surface where the plaque is ruptured, and that leads to thrombosis. And if the vessel completely thromboses, you have a large heart attack. Sometimes it only partially thromboses, and then you can have other acute coronary syndromes like a small heart attack or unstable angina. Next slide, please. All right, so let's talk about what it feels like to have a heart attack. What are ischemic symptoms? So ischemia is the state of an organ not getting enough blood flow. So what are the ischemic symptoms caused by poor blood flow to the heart? Well, the symptoms of a heart attack and the symptoms of kind of run-of-the-mill angina are about the same, other than heart attack symptoms are generally a lot more dramatic. So the most classic symptom is chest pressure, chest tightness. People sometimes say it feels like it's squeezing. It's usually under the sternum or to the left side of the chest. And people will describe it like an elephant sitting on their chest. Some people will have more vague symptoms. They'll say, well, I just feel a little uncomfortable. Something doesn't feel right in my chest. Shortness of breath often is a concomitant with the chest discomfort. And some people have chest discomfort all by itself. Left arm heaviness or discomfort is a common symptom, as is jaw pain or discomfort. Some people will feel like they're going to faint or at least become somewhat dizzy. Usually that's not a symptom all by itself, but can go along with the other things. And other people will break into a profuse sweat. For people having angina-like symptoms, breaking into a profuse sweat is strongly suggestive that this is actually a heart attack and not just run-of-the-mill angina. So if your symptoms persist for longer than 15 minutes, you should call 911. And the reason we came up with 15 minutes is it takes about 15 minutes from the time a vessel becomes completely occluded for heart damage to start to occur. So it's okay to take up to three nitroglycerin tablets under your tongue every 5 minutes. But if it doesn't go away in 15 minutes, go to the hospital. And you don't have to feel like you know for sure it's a heart attack. It's always safest to go and get checked out just to be on the safe side. All right, next slide. All right, so we've talked about the pathophysiology of atherosclerosis and what causes heart attacks and what they feel like. So what makes this process happen in the first place? Next slide. So what are the risk factors for coronary artery disease? The whole concept of risk factors started from a study in Framingham, Massachusetts in 1948 that were looking at demographic factors that were associated with people having heart attacks. And this is where the term risk factors came into being. Over the years, other studies have been done to discover other risk factors. Some of these risk factors are not modifiable. So although people can certainly have gender change operations, still biologically, men over the age of 45 and females over the age of 55 are considered to be at higher risk, regardless of what their psychological identity is. Your biological identity, unfortunately, determines these things. A family history of early heart disease. So if a first-degree relative, men before the age of 55, women before the age of 65, have had a heart attack or another vascular event like a stroke, then you're at greater risk. And we focus on first-degree relatives, siblings, parents, because you share more genetic information with them. But the most interesting thing are the modifiable risk factors, because those are things we can treat and do something about. These include dyslipidemia, meaning abnormal cholesterol, high blood pressure, otherwise known as hypertension, diabetes. Diabetes is such a strong risk factor that it's often called coronary artery disease risk equivalent, because people with diabetes are at similar risk to having a heart attack in the future as a person who has already had diagnosed heart disease. And then smoking is a major risk factor. Next slide. So some of the other risk factors that we've discovered over the years include inflammation. And inflammation can either be something we can measure in the bloodstream, like an elevated HS-CRP, high sensitivity C-reactive protein level, or it can be known inflammatory disorders like rheumatoid arthritis or lupus. Metabolic syndrome is a risk factor. So metabolic syndrome includes some lipid abnormalities like a low HDL, a high triglyceride level, LDLs that are small and dense, but also includes glucose intolerance. So, abnormal processing of sugar short of actually having diabetes. It also includes abdominal adiposity, so people whose waist circumference is unusually high. Another lipid abnormality that has been discovered to be a risk factor is an elevated Lp(a). Currently, we don't have any approved therapies for this, but we're actually thinking here at Pima Heart of being part of a trial that is looking at a new agent like that. So there are things being developed that can treat this. Ethnicity can be a risk factor. People of South Asian descent have an increased risk. People who are Indian, Pakistani, Sri Lankan, other areas of South Asia genetically are more predisposed to atherosclerosis. Chronic kidney disease is a risk factor. And that can include abnormal kidney function or abnormal protein in the urine. Peripheral vascular disease is a risk factor. So anybody who has other vascular beds that have disease, the legs, kidneys, the brain, are at increased risk of having it in their heart. And finally, there's some risk factors that are specific to women. Women who during pregnancy have preeclampsia, they are at greater risk. Women who undergo premature menopause are at greater risk. Please, next slide. All right, so those are the risk factors. How do we find this problem? So detecting CAD, next slide. When you come to my office or another cardiologist's office, we're all going to do a history and physical on you, measure your blood pressure, see if you have hypertension, and take a history that will include your family history, of heart disease, ask you if you smoke. We'll get an EKG. We will do lab work, or at least look at the labs that your primary has done, particularly focusing on your cholesterol levels, a hemoglobin A1C if it's not known whether you have diabetes or not. And sometimes in the right situation, we'll check inflammatory markers, the HS-CRP I mentioned. CT calcium score is often helpful. Next slide. And then other testing that we do includes echocardiography, which is ultrasound of the heart, stress testing. And stress testing can be done on a treadmill or can be done chemically. And either of these can be combined with imaging. So you can have an echocardiogram with a treadmill. You can have nuclear imaging either with a treadmill or as a chemical test. And finally, we often want to actually, whoops, one more line. Oh, back a few. Finally, we sometimes want to image the arteries, do a coronary angiogram, and that can be done non-invasively with a CAT scan, a so-called coronary CTA, or invasively with a cardiac catheterization. All right, next slide, thanks. All right, so this isn't going to be an EKG course, but I do want to show you what a normal EKG looks like. And the thing I want to point out is that most of the spikes are upward, or at least they start off upward. So in the 6 leads on the left, all of them are upward, or at least except for the one called AVR, that's actually supposed to be upward. The one in AVL goes downward a little bit, but not significantly. And the ones on the right, the V1, 2, 3, 4, 5, and 6, those are the ones when the cardiologist puts the leads across your chest. All of those start off with a little upward blip that grows bigger and bigger as you go across the chest wall. The other thing that is true of a normal EKG is that there are generally 2 other little humps, one of them right after the spike and one of them right before the spike. And if you can imagine a baseline that goes through the 2 blips and the spike, you have kind of a straight baseline. So next slide. So one of the ways an EKG can be abnormal, that can indicate poor blood flow, is that this baseline can stop being straight across. So a lot of these leads, you can see that right after the spike, that baseline is now heading downward, not going straight across. And this can be a sign of poor blood flow to the heart. Next slide. Another sign of a heart problem, we can sometimes do EKGs and find a person's had a heart attack before. Believe it or not all heart attacks lead to symptoms. About 10% of heart attacks were never felt by a person, or at least weren't recognized as a heart attack. So in this EKG, on the left side, you can see a lot of the spikes are going downward in lead 2, in lead 3, in lead F, and going on the right side, starting in lead V2, it starts going downward first and continues to be downward first into V5. So these are signs of a previous heart attack. Next slide, please. So I mentioned coronary calcium score, and you also recall that when we were talking about atherosclerosis, I told you that one of the things that leads the arteries to become hardened is calcium. What I didn't say in that discussion is the calcium has any particular role in the formation of plaque. So the plaque forms regardless of whether there's calcium or not. But what happens is that when there's inflammation, the calcium goes to areas of inflammation, embeds in the plaque, and that's what makes it harder. It doesn't make plaque bigger. It isn't what causes a plaque to rupture, but it is something you can image because calcium is very easy to see on a CAT scan in a way that soft plaque is not. So in the image here, you can see the arrow pointing to this bright white area. That's calcium in one of the coronary arteries. And you see that it's white, kind of like the sternum that's at the top of the screen or the spine that's at the bottom of the screen. And we can actually measure how much calcium is in the arteries and develop a score. We can compare that score to other men and women the same age and come up with a percentile risk. So coronary calcium scores are a way of detecting the presence of atherosclerosis by looking at one of the hallmarks of what is present in atherosclerosis, which is calcium. Next slide. Stress testing, we do a lot. Here's an image for those who can't read the small print. It's not looking good. His pulse is up to 202 just from getting out of the chair and stepping on the treadmill. So we do like to do stress tests on people, but we do have to be careful who we put on the treadmill. We won't usually put people on the treadmill who huff and puff just walking across the room. Next slide. So this image is of a person who's in a little bit better shape. My partner, Dr. Lancero, is doing a treadmill test on him. And what we look at is the EKG and what changes may occur in the EKG on the stress test. Next slide. And here's what an EKG might look like. So again, what we see is ST depression. The ST segment is that flat area right after the spike that's supposed to be at the same level as the area right before the spike, but here it's depressed. It has dropped below that baseline. And this is a sign of a person who is having insufficient blood flow to the heart, has what's called an ischemic response to exercise. Next slide. So turning to echocardiography, ultrasound of the heart, you've got a technician here. She's got a little echo probe that she puts on a person's chest and can bounce sound waves off. Next slide. And this is what an echocardiogram looks like. So you can actually see the heart contracting. In the upper right is the left ventricle, and the upper left is the right ventricle. The atria are below that. And here we can see that the heart muscle is contracting nice and normally. In a person who's had a heart attack, one of the walls doesn't move very well. On a stress echocardiogram, we might find that it looks like this at rest, but with exercise, one of the walls stops moving very well. So that's how we use echocardiography to look at coronary artery disease. Next slide. So we talked about nuclear imaging. This is our PET scanner at Pima Heart. PET scanning is a special type of nuclear imaging that uses less radiation and gives more detailed, more accurate images. And the PET scanner looks a little bit like a donut. And what happens is a person gets the nuclear isotope after getting a chemical stressor, and then images are taken to see where the isotope goes. Next slide. And the report that is generated looks like this. So with a computer, it takes sort of slices through the heart and can, like slices in one plane, slices in another plane, and slices in the third plane. And that's why you've got sort of three sets of images there. And you can see all parts of the heart and do they get a good blood flow or not. If the nuclear isotope is missing from an area, that indicates that that part isn't getting a good blood supply. Next slide. This is our CAT scanner at Pima Heart, and it looks a little bit like the PET scanner, but the donut is bigger, the hole is bigger, and with this we can do all sorts of CAT scans, but in the context of a coronary CAT scan, a coronary CTA, next slide, we get images that look like this. So on the left you see a normal artery with everything looking like no narrowing. The next image shows a little hunk of calcium at the top there with a bit of narrowing. So this is a sign of atherosclerosis, but not bad enough to cause problems. The next line shows more calcium and possibly a significant narrowing. And the fourth image shows so much calcium that you actually can't even tell how narrow the vessel is. Because calcium, while it's good on a coronary calcium score to detect the general presence of plaque, it's not good at determining how narrow a vessel is, because the calcium actually causes shadowing and what's called blooming artifact that makes the calcium even bigger than it actually is and obstructs the image of the artery. So in this image, we need some type of stress test or functional study to assess things. But in the fifth image, about 2/3 of the way down, there's a very severe narrowing there. And this is a person with a high-grade narrowing, high-grade stenosis, who will probably need to have a coronary angiogram. Next slide. So speaking of coronary angiograms, this is our cardiac catheterization. We have an ambulatory surgical center at Pima Heart. We're going to be rolling out another one in partnership with TMC in the near future. And this is how we image the coronary arteries with catheters. Next slide. And with such a procedure, we get these nice pictures of the arteries, usually a bit more detailed and accurate than we can get with a coronary CTA. The images on the left are of the left and right coronary arteries that are normal. The image on the right shows a very severe narrowing in a vessel called the LAD, the left anterior descending. And often we can fix the vessel at the same time. Next slide. All right, so this is how we detect coronary artery disease. Lots of different ways of looking at it. Each person might get one test versus another. Sometimes people get more than one test depending on the findings. So once we find this disease, what do we do? What do we do to prevent events? What do we do to treat symptoms in previous events? Next slide. So I like to think of prevention and treatment as a partnership between the cardiologist and the patient. The role of the cardiologist is to do several things, one of which is to give advice to the patient on what they can do. So the things the patient can do is control his or her weight. We think of an ideal body BMI, body mass index, of being between 20 to 25, although I will say that studies in older people around the age of 70, show that an ideal BMI is closer to 30. So I don't always push people to get well under that number, but certainly if you're over 30, we want to try to get your weight down. Diet is very important. Look up Mediterranean diet if you want to know what a heart-healthy diet is. That's a diet that's low in saturated fats and uses healthy fats like olive oil, low in simple carbohydrates. So you don't want processed carbohydrates or processed sugars. Brown is better than white when it comes to starches. Lots of fruits, lots of vegetables, nuts, lean meats like fish, and the white meat of chicken. Exercise, critical for everybody. Even if you don't lose weight from exercising, exercise is inherently beneficial to you. And the goal is to exercise at a moderate intensity for about 150 minutes a week, divided over 4 to 5 days. So 30 to 40 minutes for 4 to 5 days. Moderate intensity means that you're exercising vigorously enough that you can tell you're breathing more heavily, but you're not gasping for air. You can answer questions if somebody is talking to you, but you can't hold a fluid conversation. You can't talk as quickly and nonstop as I'm talking right now if you're exercising moderately. And then smoking cessation is very, very important. So the other things our cardiologists can do is manage the blood pressure through medication, also through diet, lowering sodium, and actually weight loss is very helpful for blood pressure. Cholesterol management, in addition to diet, includes medications, the backbone of which are statins, but there's lots of other medications now we have in our armamentarium. And diabetes management, keeping the sugar optimal. That's something usually that the primary care physician is overseeing. Next slide. So what are the goals for these risk factors? If you have any of the top conditions there, such as known coronary artery disease, symptomatic vascular disease like severe blockage in the leg vessels, the carotid arteries, previous stroke, or high risk by the Framingham Score. So I mentioned the Framingham study. You can actually go online, Google Framingham risk score, and you can see what your risk is. And if it's over 20% over a 10-year period, because that's what it looks at, is what your 10-year risk is. If your LDL is at least 190, you should be on a high-intensity statin medication. People with diabetes should be on a statin, at least a moderate intensity, but consider a high intensity if you have other risk factors. And by the way, high-intensity statins are atorvastatin and rosuvastatin. Those are the most potent statins. Other statins include pravastatin, simvastatin, lovastatin, pituvastatin. Intermediate risk patients who are in the 5 to 20% range should consider a moderate intensity statin, depending on other factors. Do they have other risk enhancers? And we talked about these risk enhancers on a previous slide, and I listed them there. And these are people that we often do calcium scores in. So this is one of the main roles of a calcium score, is to look at people who are at intermediate risk, where you say, gee, how aggressive should we be? Does this person need to be on a medication? Do they not need to be on a medication? Is their borderline high blood pressure something we need to take more seriously, a calcium score can help answer that question. And then low risk patients who are under 5% risk over 10 years, we usually just recommend lifestyle modification. So it doesn't mean they're not at any risk, but we start conservatively, healthy diet, exercise, weight control. Next slide. When it comes to hypertension, the new goal is to treat to keep the blood pressure under 130 over 80. It used to be 140 over 90, but we discovered that people were having less heart attacks and strokes and other bad things when we kept their blood pressure lower. So that's our goal for hypertension. For diabetes, the goal is to keep the hemoglobin A1C between 6 and 7, keep the fasting sugar between 70 and 130, and a post-eating or postprandial sugar of under 180. And the goal for smoking is none. There's no safe amount of smoking. It is true that if you smoke less, that's better than smoking more, but you can't rest on those laurels. The goal should always be to completely stop. Next slide. So what is the medical treatment of coronary artery disease? Anybody with known coronary artery disease should be on aspirin. So you've probably heard these studies that show that maybe people don't need to be on aspirin, but these are people that don't have known heart disease. The average person who is feeling fine and doesn't have lots of risk factors or known heart disease shouldn't be on aspirin. But if you have heart disease, have coronary artery disease, definitely should be on aspirin. When it comes to treating angina, beta blockers are the first line therapy. Medications like metoprolol, atenolol, bisoprolol. Another category that is helpful are nitrates, so the nitroglycerin that people put under their tongue, sublingual nitroglycerin, or we often put people on a long-acting nitroglycerin to prevent episodes, isosorbide. Calcium channel blockers can be helpful, particularly when people also have hypertension, since they're good blood pressure medications too. So amlodipine, diltiazem, verapamil are the most common ones we use. And then there are other categories that have come out over the last 10 or 15 years, ranolazine and ivabradine. Next slide. Sometimes people's symptoms need to be treated invasively. Either they have refractory symptoms despite being on medicine, or they've had a stress test or a study that shows a high-risk situation. In those people, we turn to invasive procedures like angioplasty or percutaneous coronary intervention is the general term for it, that includes balloon angioplasty, stents, atherectomy. And atherectomy is a procedure where we actually remove tissue, either with a rotor-rooter procedure, rotablator, looks kind of like a drill bit that pulverizes the plaque, or with laser. And some people need bypass surgery. So bypass surgery is done by taking either an artery, usually from the inside of the breastplate, so-called arterial conduits, or vein conduits from the legs, and use that to bypass the blocked vessels. And the choice between these two kind of relates to where the blockage is, how extensive it is, how high risk a person is for considering surgery. All these things go into play in choosing between those two modalities. Next slide. So I want to finish this lecture with a little bit of show and tell. These are some images of stents. You see on the upper left, the stent on the balloon. On the right, you see stents against a person's finger. The one on the left is expanded. The one on the left is before it's expanded. Next slide. And the way we deploy these stents is we put a wire down the vessel, and you can see the wire there. That's not actually a spear or a spike. That's just the artist's rendition of a spike, the wire disappearing into the distance. And over the wire goes a balloon with a stent mounted on it. When the balloon is expanded or blown up, the stent expands. It gets embedded into the artery. It pushes the plaque out of the way. And when the balloon is deflated and removed, the stent stays in place and acts like scaffolding to hold the vessel open. Next slide. So this is an image of an angiogram I did about a decade ago on a young gentleman having a heart attack. And if you put your cursor in below the gray image, or at the bottom there, and push the button there, the arrow. So you see a very severe narrowing up there. And the rest of the angiogram shows mild blockage in other vessels. As I said earlier, mild blockage turns out to actually mean that there's still a fair amount of plaque there. There's probably moderate blockage in this artery. And the way we open it up, as I said, is we put a wire down the vessel and blow up a balloon in the artery first. That doesn't open up the vessel much, though the blood flows better. And then the stent is deployed and expanded with the balloon. And at the end of the angiogram, the vessel is nice and open, blood flows normal, and the person stops having chest pain. And that stops the heart attack in its tracks. So the damage that's been done before a person arrives at the hospital can't be undone, which is why you should get to the hospital as soon as you think you might be having a problem. Don't wait to confirm it. Come to the hospital. It doesn't hurt to be told your heart looks fine and go home. But it's very bad to sit at home and have a heart attack and miss an opportunity to save heart muscle. Next slide. So in summary, coronary artery disease is a progressive disease. It has a long period that is asymptomatic as the plaque is first growing outward and then starting to grow inward. Risk factors can be identified and they are treatable, which help prevent events from happening. It's important for you to know what the symptoms of cardiac ischemia are so that you can get prompt attention. And prevention and treatment is a partnership between the patient and the physician. We discussed many medical and invasive approaches to detecting and treating coronary artery disease. So there's a lot of options we have. So that concludes. Thank you very much for your attention, and thank you, Maya and TMC Healthcare for inviting me.
So thank you so much. I've got a couple of questions that have come up that I wanted to ask, and one is regarding stents. So how long do they last if you had to go in and have a stent done?
Sure. So technically a stent lasts forever. Stents don't degrade, although there are stents that are actually made to degrade. Most stents, 98% of stents that are put in are not that type of stent. So they stay there forever. What can happen to a stent, though, is that tissue can grow inside the stent and re-narrow the stent. Interestingly, though, that process usually happens relatively early. So if it's going to happen vigorously, it usually happens in the first year or so. And so people who have old stents, they don't eventually fail. The stent, if you make it through those first couple of years, it will probably stay open indefinitely. That's not always the case, but that's mostly the case. And people who have problems 5-10 years after a stent was put in, chances are it's in a new part of the vessel and not in the stent.
Okay, well, that's good. Now, if somebody was looking to have an appointment, they would like to come see you, they need a cardiologist.
Mm-hmm.
I did just put the number up for Pima Heart and Vascular, so 520-838-3540. You can also go to their website at pimaheartandvascular.com. I do have, let's see, I had another question come in about should you focus on dietary cholesterol or saturated fat?
Good question. I would focus on saturated fat. It's one of the paradoxes of the whole lipid issue is that the things that you're looking at changing aren't necessarily the things you change in your diet. So saturated fat intake predicts your cholesterol levels a lot more than your cholesterol intake. Similarly, if you look at triglycerides, which are fatty molecules, those go up more because of how much sugar and starch you take in than how much fat you take in. So it's not always self-evident what you would do in that for treating those things.
And what about if you've had a heart attack, is it too late to benefit from, for instance, cholesterol lowering drugs, or would your treatment just be completely different at that point?
Oh, absolutely not. So it is true that if you've had a heart attack, you can't undo the damage. But if we're having this conversation, it means you survived your heart attack and you can have another heart attack. And if you lower your cholesterol, you can slow the process of plaque formation and make it less likely that another heart attack occurs. And if you get your cholesterol really low, we actually can see regression of plaque. So we can see reversal. There's a lot of plaque in our arteries in different places. And people often ask, well, will it go away? Some plaque may stabilize, some plaque may get worse, some plaque may get better. The lower your cholesterol, the more you favor it stabilizing and regressing over progressing.
That's very interesting. And I actually found that coronary remodeling that you were sharing was fascinating, and just the difference in the shape.
It's not something that people would say is self-evident. When I remember when I'm not even sure we learned this in medical school. I don't think I learned that until I was a cardiology fellow. And it was very surprising for me to learn it too.
Definitely. All right. So I think that's all the questions that we've got that have come in today. I want to thank you so much for being here. We are continuing on with Heart Month, and our next talk is going to be on Tuesday, February 15th. It'll be symptoms and tests for heart disease with David Strout. He is also with Pima Heart and Vascular. So we hope you'll join us then. He'll be on at 2 p.m. Please feel free to give us a call in the office if you would like the link to that presentation as well. And I want to thank you so much for being here, Dr. Koshkarian.
Thank you. It was my pleasure. Thanks very much.